The idea is to really expand the ability of community providers to provide care for patients with complex disease related to obesity. So we want to be able to expand what kinds of services kids and families can get in their own community from their own pediatrician.
So typically we start with 20 minutes of a presentation, usually something that's been suggested to us by providers or something that's come up when we've talked about patients in COMM-TC. After that, we have about 10 minutes of questions from participants, and then we start into our case consultations.
Well, I want providers to know that COMM-TC is really an excellent opportunity. It really does make a lot of sense to have consultants from different pediatric disciplines all together in the same room.
In the other situation, we end up with systemic insulin resistance that's pronounced, and we end up with what we can diagnose as impaired glucose tolerance.
So I think having a room of expert consultants in cardiology, endocrinology, nephrology, psychiatry, motivational interviewing, and nutrition is just completely invaluable, particularly for those rural providers who do not have ready access to those services.
I know lean body mass is an issue. We can't use their overall weight as a marker of how they're doing nutritionally.
Yeah, because our population is the population where a quarter of them have some sort of syndrome.
Mm-hmm.
And if it's rare enough, you don't have the growth chart for
Right.
that syndrome. And this idea to generically try to get them heavy is...
Right, and we're all trained that way initially.
The most valuable thing is the sense that you aren't practicing alone with these complicated cases, that there are people out there trying to figure out a path, a better way to support these kids and families, and that you can use other people's strengths and expertise to add to your own. You know, there's this great sharing and camaraderie that happens. I think that's the most valuable.
So it makes the overwhelming problem of obesity much easier to deal with.
And a few years ago, when he started to have vision problems, he was referred first to an ophthalmologist here in Albuquerque, and then later to an ophthalmologist in Portland, Oregon, because of some unusual findings.
So I'm going to go ahead and start with a couple of the first two questions. So this is one of those rare syndromes, and you're right, it's very similar to Prader-Willi with distinct differences.
We always want to start low and go slow with these medications in the pediatric population, and especially for an individual with a profound developmental disability, we want to be even more careful.
The collaboration among disciplines is just really fantastic, and coming from a primary care background myself, I've used the service from my clinical perspective, and it's just really nice knowing that those resources are available, that you don't have to figure it out alone or take a risk or make a decision without help.